For those that don't know, Andrew Vickers is the chief of the Biostatistics department in Memorial Sloan Kettering, New York. And I think probably all of us know your work because you publish a lot. And so feel free to start.
Okay. Well, just to comment, I'm not the chief of statistics. I for the urology, I'm in charge of all the statistics done for urology, but not for the whole. So maybe we should just start with a show of hands. I can actually see you.
That's good.
You can see me, right?
Yeah, sure.
All right. We'll move on to the slides in a little bit. So a little show of hands. Who here has ever been on a paper? They've been an author on a paper in which there was a p-value, a p-value cited in the paper. We have a show of hands?
Yeah, probably. I think everybody.
There you go. Yeah. Been on a paper, not quite. Who's ever read a paper with a p-value on it? You read a paper?
Yeah.
That looks like everyone. Okay. So would anyone like to try and give me the definition of a p-value? We'll give it a try. I see you handing the microphone around. Anyone want to give it a shot? You're all a bit nervous. Look, here's the thing: is you can only get it wrong, so that's the worst that could happen. You want to try it?
Breno in Salvador, probably. Hey, Breno.
I get this p-value as the results will be 95, at least if it's under 0.05, we have 95% concordance with that results.
Okay, so look, I comment on that, which is, someone there volunteered to be the sort of sacrificial lamb, right? Because none of you know, right? Does everyone really think they know? Put up your hands if you think you know what a p-value is. Yeah, no one put up their hands, right? So you're very brave to volunteer. You got it completely wrong, but that's fine, because most people do. But it's kind of ridiculous. We've got somebody else wants to comment. Here we go. Hi there.
Hello, how are you? My name is Leo. The p-value would be the chances that some event is by chance. For example, if you have like a less than 0.05% means that less than 5% of the chances that the event that we study would be by chance, not because of the real effect of the trial.
Yeah, so that's also completely wrong. So, I mean, it's kind of remarkable, isn't it, right, that there's this very basic concept that you all have been on, you read papers all the time on a p-value, and you even write papers. You're a co-author of a paper that has a p-value, and you don't know what the definition is. You can't really explain it to me. You're nervous about doing it, and then when you try, you actually get it wrong. And I think what I really want to talk about today is some of these underlying statistical concepts, right? Because it's really the concepts that are the issue. So I'm going to try and go to my slides right now. Let's see what happens. So if I go like this, okay. So what I can do is I'm going to minimize this one now. Oops, there we go. Okay, so you can see all the slides. You can see a slide there. Whoa, mustn't do that. You can see a slide?
Yeah. Yeah.
Okay. So I'm going to talk about some statistical slip-ups and how to avoid them. And can anyone spot the error in this? By the way, anyone can just shout out. They can spot the error. All right, no, it's a trick question. There isn't an error there, but I think that's what most people think a statistical error would be. It's some deep math thing. And I think, as I've just shown, that's not really the issue at all. Most of the errors in statistics are really conceptual. And the problem is that people don't understand the concepts. And I have to tell you, I run a large team of statisticians here at Memorial Sloan Kettering. And very, very commonly, someone will come into my office and I've got this problem because I wanted to do this type of regression, but the investigator said this and blah, 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 and I was doing it. And I will say something like, what's the definition of a p-value? Or is this inference or is it estimation? And I'm just saying, what's the concept? And they're like, oh, get what you're saying, Dr. Vickers. And then they go away and do the right answer. It's not that common that I'm getting involved in the sort of technical aspects of the math. It's more that I'm speaking conceptually. And so here's a really good example of this. Can everyone see that? That's Bill Gates there in the middle, who's the chair of Microsoft, who owns Microsoft, and this is with a bunch of Boy Scouts. And now, does anyone want to call out, if we had to say what the salaries were, the weekly salary, so let's assume that Bill Gates' weekly salary is, I don't know, $5 million. And these Boy Scouts, their weekly salary is, $10. And here's a group. Would we want to report the mean salary or the median salary? Well,
probably median, right? Everybody's
probably median, right? Yeah. So here's the thing: is that it's not difficult to calculate a median or a mean, right? My 10-year-old kids are taught to do this in their math class. That's not difficult. But actually, whether you use a mean or a median is a discussion. So, for example, you've said a median, and I presume you said, let's report a median for, in this particular case, because if we report the mean, it's not going to give it's not going to describe the data set very well. If we said here that the mean salary was, I don't know, $250,000 a week, that would give people the impression that all of these people were earning close to $250,000 a week, whereas in fact they're not. Most of them are earning $10 a week, and one person is earning many millions of dollars a week. And so I think that's why you had that intuition to talk about medians. However, there are other circumstances where we might want to use the mean, in fact. So let's imagine that instead of talking about weekly salaries, that we were talking about the cost to the medical system of these individuals. So most of these individuals had cost the medical hospital or whatever $10, and one had cost the medical hospital $5 million. Would you then use the mean or median? Any thoughts?
Yeah, people.
You've got a plan for next year. How much money are we going to need to put into the hospital system?
Mean, probably, right?
I'm sorry?
Probably mean then, yeah.
Yeah, exactly. If you use the median, then you're not going to have enough budget. And in fact, when you're doing economic planning, you often have these huge outliers. Most patients cost the same, and then one or two patients have complications and things go wrong, and they cost enormous amounts. Now, that's very skewed data. And we say, oh, it's skewed data, we have to use the median. But in fact, it depends what you want to use it for. To describe what's going on, yeah, the mean seems to be misleading. But in order to make decisions and plan, actually you want to use the mean rather than the median. So what am I going to talk about in this talk? So first of all, I'm going to talk about the number one statistical slip-up of all time. I'm going to tell you about some other slip-ups, and then we'll go back to and talk about how to solve the first big problem. So does anyone know what this individual is called? Does someone know who this is?
No.
No. Okay, so this is R.A. Fisher. You may have heard of Fisher's exact test and ANOVA and principal components analysis. This was one of the forefathers of statistics. Invented many of the techniques that we currently use. And perhaps the only slip-up you need to avoid is not actually needing a statistician, right? So if you go home with any message, it's that a big mistake is saying, I can do this myself. I don't need a statistician. And this is the only reason why we think we can do statistics ourselves, is because of these advanced software programs we have on computers. If you look at, this is Fisher again, he had to use a counting machine. And if you can see that in the bottom right, it was very difficult to do math back in the 1930s. You had to be very good at math and really know your formulae in order to get any statistics. Now we can actually just get some software, get some drop-down menus, and end up doing a negative binomial regression. Does anyone know what a negative binomial regression is? Presume not. No. But would that stop you actually doing one? No, right? You could still get your computer to run an analysis that you had no idea what it was. Now, this actually is not a trivial problem. I'll tell you a real story. Something that really happened to me is that I was at a meeting, and it was lunch, and people were milling around. And I overheard one of my colleagues talking to a surgeon. So the statistician says, oh, wait a minute, you already have calculated the p-value. I thought I had to calculate the p-value. And the surgeon says, no, I've already done it. And the statistician said, well, how did you do it? And he said, I used multinomial logistic regression. And my colleague said, well, my goodness, how did you come up with that? That's a really complicated technique. And the surgeon said, well, I went through every single option on SPSS, and that's the one that gave me the lowest p-value. Right. So you can do it, right, using computers, but I really don't think it gets to the essence of what statistics is all about. And I think when most people think of biostatistics, this is what they think of. They think of math. And that is really a very anemic view of what we do as statisticians. Now, because it's biostatistics, what we do is we convert biology into math, and then we do some math, we do some statistics analysis, and then we get some results, and we convert that back into the biology. And converting the biology into the math is you're going to come up with, to my group, with some kind of idea. Yeah, we've got this idea that we're worried that doing a lot of biopsies on patients with prostate cancer could lead to an increased risk of erectile dysfunction after radical prostatectomy. And then we might say, well, what's the mechanism of that? And I think, well, it could be inflammatory. And so then we've got to think, okay, so let's look at patients who got radical prostatectomy shortly after their biopsies. And we'll have a long conversation. At the end of that, we're going to end up with a mathematical hypothesis, a null hypothesis. And then we'll do a lot of statistics, and we'll come up with something like an odds ratio. And then you can't just report the odds ratio. You've got to turn that back into the biology. Now, if I was an economist, instead of saying biology, I would say human economic activity. The purpose of economics is to convert economic activity into math and then back into economic activity. If I was a psychometrician, it would say psychology. So that's the interesting thing about biostatistics. And, computers do help with the math. It makes my life very much easier. But obviously, computers don't help turning the biology into the math or turning the math back into the biology. The other thing is that it is actually easy to mess up the math. And so I just give this paper as an example because it is in our field of urology, but there have been literally dozens and dozens of papers that are very similar. And what they do is that they will choose a certain set of papers, whether it's urology or dental care or anesthesia, and they will just pull the papers and they'll give them to a bunch of statisticians. And they'll say, please read these papers and have them analyzed. And analyze the papers to see if they did the analyses correct. So this is what they did in urology in 2004. And so they looked at European Urology and the Journal of Urology and BJUI. And there were 83 studies that reported statistics in August 2004, and 69 of them had an error, 71%. Now let's imagine that you came to Memorial Sloan Kettering and you watched a whole bunch of operations and you said that 71% of them had an error. That would be seen as disastrous. And yet, you make an error in the operating room, you may threaten the life of one patient. You make an error in your statistics, that could affect the care of hundreds or thousands of patients. So this is a very major problem. And I've seen it in my own work. So some of you may know that I'm the statistical editor of European Urology. And we've written some guidelines that I'll describe later. And to write those guidelines, what we did is we read every paper in European Urology, starting from the most recent and going backwards. And I think Dan Soberg and myself, another statistician colleague here at Memorial Sloan Kettering, I'm pretty sure we got to, I think, the 16th or 17th paper before we found a paper that didn't have any errors in it. They're absolutely ubiquitous. This is just another little experiment I did. I just decided to do a search on PubMed for urology, and I decided let's have a look at the very first paper. So the very first paper is association of statin use with improved local control in patients with bladder cancer. This is an epidemiologic hypothesis. It has almost nothing to do with the practice of clinical medicine. And yet, the only people involved are, there are no statisticians on the paper. They're from the radiation oncologists and medical oncologists involved in the paper. If you go down to the abstract, this is the very first number that is reported in the paper, and it's wrong. I don't know if you know this, you never report the median follow-up time for all patients. You should report it for survivors, that makes sense, this one. But this is a nonsense number that doesn't mean anything. So just to go over what we did, we pulled the first paper on urology, there were no statisticians involved, and the very first number that they report in the abstract is erroneous. So what I'm going to show you now is, this is some programming code. If you came to my offices and watched a bunch of statisticians working, what you would see them doing is programming computers. And this, the programming computers is not straightforward. It requires a lot of skill and time and effort and sweat. And I'm just showing you some code that is written. These programs that are written to analyze data are often hundreds of lines long. And I'll show you what that code that I just showed you does. So this is the sort of thing that you may see in, if you run a statistical program. This is the sort of output you might get. And so here we are, what this is a little analysis to saying, you know, what's your risk of recurrence within 2 years, depending on whether you have a high-grade tumor, your stage grade, basically. And you'd want to report this in a paper with odds ratios and confidence intervals and p-values. The problem is that this is the sort of output that any statistical program will give you. So, for example, it tells you that the log likelihood is minus 72.704458. It also gives you the odds ratio to extraordinary level of unnecessary precision, 4.234603. And what you actually want to say is that the odds ratio is 4.23. So how are you going to actually take this statistical output from your statistics software and get it in the paper, in the Word document or whatever word processing software you use? And I think what most people do is they just cut and paste. And that obviously can lead to errors. And I've seen this happen numerous times. I can just tell you one story that happened is in a randomized trial. They did one of these regression analyses, and one of these are called the predictors. So one of the predictors was whether you got treatment or not, and that's what we were interested in. And the other one was what was your baseline score, and which we, was for a trial on pain. We're pretty sure that your pain before treatment is pretty highly correlated with your pain after treatment. Well, what had happened was that the investigators had said that the treatment works brilliantly, very, very low p-value, and what they'd actually cut and pasted was the coefficient and the p-value for baseline pain score. And it turns out that the treatment they were looking at didn't work at all. So that's a difficult problem. We wrote all that statistical code in order to do this, to get the format to look like that. And the reason, so instead of coming out with lots and lots of numbers that we don't need, we focus on the numbers we do need in this special format, because that can be cut and pasted into Word. You can select it, hit a button, and get a table that looks like this. So it's all properly formatted, the variables are correct, it's got the right number of decimal places, and the p-values are appropriately rounded. So it 0.003, but if it's a high p-value, we don't do it to 3 decimal places, we just do it to 2. And the same software, if the p-value is very much lower, would say p less than 0.0001 or whatever. Okay, that prevents errors such as the one I just described when you're cutting and pasting from your statistical software into your Word software. And so if there's nothing else that you remember from today's talk, do remember this. If you go and speak to someone at the end of their career who's done a lot of good clinical research, they will tell you, how I was able to do this is I worked with a great statistician, or or statisticians, or if I hadn't worked with Bob from CLGB, we never could have done those trials. They will always say this. And so that's what your challenge is to find some good statistical support. So I've talked about sort of error number one, or error zero maybe, which is not having a statistician. I'm going to give you a quick tour of some other ones. There are way more than 6 statistical errors you can make. I'm just going to start with 6 as a start. Okay, so let's start with this one. This is an email I received, and you can see that I've redacted. I've to hide the guilty parties. I'm not going to say who it's from, but you can see there's no subject and there's no text, and it's just an Excel spreadsheet. And I wrote back and I said, "Thanks, dear doctor, thanks for sending the spreadsheet through. I presume this is from the nodes database. What was it you wanted to know? I have an abstract deadline on Wednesday and I need the p-value." And I think this is the first mistake, which is the idea that a statistician is a machine for converting data into p-values. And that's just one of the things that we do. So one of the first things to know about statistics is that there are 2 very different things that we do. So the first thing is inference. Is something there? Is this something in Brazil, Bigfoot? Do you know about this? Like it's a big ape that likes to live in the woods of America, right? So the question is Bigfoot there? So we say, what's the p-value for Bigfoot, right? So what does the drug work? Is there an association between the marker and the outcome? So that's inference. The other thing that statisticians do, and it's actually most of what I spend my time doing, is estimation, right? So is Bigfoot there? Well, how big is Bigfoot? How big is it? Estimation. And that's when we're doing things like, we're not looking at p-values, we're looking at means, medians, proportions, or measures of association, such as a coefficient in a regression model or a correlation. And there's lots of other things that we do. We help you think through the question. That's very early on in the research. One of the main complaints statisticians have is when investigators come to us once they have all the data and they've done the study and say, "Can you analyze it?" We say, "Bring us in at the beginning. We can help you think through the question. We can help you with study design. We can also help you with data gathering." So this may surprise you. This is something we do at Sloan Kettering, which is questionnaires that we give to patients, and they're done online. So rather than give them pieces of paper to fill in, we give them questionnaires online. And here's something that we might give to a patient after prostate cancer, and it's saying, are you able to have sex after your prostate cancer? It's actually my group, this may surprise you, it's my group that is in charge of actually putting these questionnaires together. Why put a statistician in charge of a data gathering exercise? It's because we understand data. We understand the problems of having missing data and how important it is to avoid missing data. The other thing we can do is help you interpret your data. Right? You're going to get some kind of result. You're going to get a low p-value, a certain odds ratio. So what? What should I do with that? Well, that's where our expertise comes in. We understand what these particular metrics mean. Okay, so this is a second slip up. This is Lionel Messi. That's actually me with Lionel Messi, and I'm not lying because I'm a statistician. But anyway, we're playing one-on-one, and he beats me 7-1. But the p-value is 0.07 for me, whether I'm a better soccer player than Messi. So what's the conclusion? He beats me 7-1. It's not statistically significant. So the obvious conclusion is that I could have led Barcelona to the championships, European champions. I mean, it's kind of ridiculous, isn't it? No one would think that because Messi isn't statistically significantly better than I am, that I'm just as good as he is. But that's a mistake made over and over again in the literature. And here's a very well-known example. This was a trial done in the US. And what they did in the trial is women were randomized to go on a low-fat diet or just to eat their normal diet. And at the end of the study, they actually monitored how much breast cancer there was in each group. And it turns out that in the women eating a low-fat diet, the rate of breast cancer was about 10% lower than in women eating a normal diet. Now, you take that worldwide, that is maybe thousands of women throughout the world who would avoid breast cancer if they changed their diet. However, this is how the trial was reported. Low-fat diets flub a test. The war on fats has been in vain. Why are they saying that? Because the p-value was 0.07. Now, that's a terrible error to say because it was not statistically different, it's the same. And so just to get it, so everyone's really clear on it, what's the basic introduction to inference? Remember, we do these two things. Inference is something there, estimation, how big or small is it? When we're doing inference, start by stating a null hypothesis. There is no association between marker and outcome. Low-fat diets have no effect on breast cancer rates. We're going to get a data and we'll calculate the p-value. And then it's actually pretty easy. We either reject we either reject the null hypothesis if the p-value is small, and if the p-value is large, we don't reject the null hypothesis. Saying that I'm just as good as Messi or that low-fat diets don't work is what's called accepting the null hypothesis, and that's invalid. Just like in a court case, I don't know if this is the same in Brazil, but in the US, you can either be found guilty or you're found not guilty. You're not found innocent, right? So same thing in statistics. We're going to reject the null hypothesis or we're not going to reject the null hypothesis. And in terms of that, it's really not difficult to do. So the Earth is bigger than the moon and the sun is bigger than the Earth. It's really that easy. Your p-value is either bigger than what's called the alpha, 5%, or it's smaller than 5%. No ifs, no buts about it. And yet what you read in the literature is that the result was a trend. Have people heard of that, a trend? Or they say it's approaching statistical significance. I read a paper and the p-value was 0.07, and it said it was approaching statistical significance. And so I shut the journal, came back the next day, opened it up, and it was still 0.07. It hadn't approached statistical significance at all. So there's no trends or approaching. It's either statistically significant or it is not. The sort of language that we use in our papers is things like, we did see some evidence that the drug was effective, although it did not meet conventional levels of statistical significance. Okay, so here's the third statistical slip-up. So it says that randomization, there was a statistically significant difference in age between the drug and placebo group, or by the same token, erectile function decreased in older men during the 2-year follow-up period, and it's given a p-value. Now, normally I'd ask the audience to say what they thought the problem was, but that's sort of difficult to do now, so I'll just tell you. You often see in randomized trials this type of results. So they'll have a table 1, and they'll say, what was the age or the pain score or type of cancer or whatever it is in the drug group, and what was it in the placebo group, and what's the p-value between them. Well, informally, what the p-value is telling you, and I'm going to come back to the formal definition later. Informally, what the p-value is telling you is whether the difference that you are seeing, that you observe, is somehow real or whether it's due to chance. In a randomized trial, we know that any differences are due to chance. So that p-value is testing a hypothesis that we know to be true. The null hypothesis here is that there's no difference in age between patients randomly assigned to drug and randomly assigned to placebo. And we know that to be true. So we shouldn't be testing that hypothesis. And the same is true of the second bullet point. Does erectile function decrease in older men over time? Yes, it does. So why are we testing that as a hypothesis? It doesn't make any sense whatsoever. Don't test hypotheses that you know to be true. And so that's part of a wider problem in terms of use of p-values. So this is a paper I received from a fellow. The fellow had done all the stats himself. And So I just, there was no correlation between grade and multifocality, although each tumor focus volume was correlated with Gleason grade. There were small index tumors, had tumor foci compared to large index tumors, and it went on and on and on. There was no difference in location between clinically significant and insignificant tumors, on and on and on and on and on. And that wasn't even getting to the tables, right? There were just table after table after table. And I actually did a little, I counted up all the p-values in the paper. I think there were 145 p-values. But there were only 120 patients in the study. There were more p-values than there were patients. I really don't think this was because the fellow was lying in bed and saying, you know what? I wonder if clinically significant and insignificant tumors are in different places in the tumor. That would be the most fascinating thing to find out. And then going on to say, I wonder if there are more tumors in one zone than the other. Let's find that out. He wasn't lying in bed and sitting through and thinking through that there were 145 things he really wanted to know about this data set from this data set of 120 patients or so. And I think actually what's going on is that probably just stuff is getting thrown into the statistics software and, let's compare this and let's do a chi-squared of that, and you end up with tons of p-values. So every single p-value tests a hypothesis. You think carefully about the scientific questions you want to ask. That's what the problem that the fellow had, is he was just doing analyses and doing more and more analyses, not thinking about what it was he really wanted to know. And again, part of that is thinking, we may know the answer to this already, or it may be a stupid question. If that's the case, don't run a statistical test. Okay, a statistical test, a p-value, addresses a null hypothesis and therefore implicitly addresses a scientific question. So this is the fourth statistical slip-up that I want to discuss today. This was from a very famous paper in JAMA. And so, in the start of my career, we thought of obesity as really being a problem of particularly middle-aged men. So, a guy's overweight at 50 or is obese at 50, and he ends up getting a heart attack at 62. This paper really changed the field because what it said was that if you're obese as a teenager, you're more likely to be dead in your 30s. So what's the problem here? The problem here is if you read the conclusion is the same as the results. Now, we don't do a big study with thousands of patients and hundreds of hours of labor and analyze all the results and write them up to not come to any conclusions, just to sort of numbly repeat the results. We want some implications, and those implications can either be for research or for clinical practice. So when you write a conclusion, you have to, first of all, sit and think through, are there implications for how we practice medicine? Now, for this particular paper, it's an epidemiologic paper, so it all really depends on whether you think there's a causal association here. If you believe there's a causal association, then your conclusion would be something like public health efforts should be initiated to reduce obesity in young women. If you're not sure whether it's causal or not, your conclusion would be further research should be undertaken to understand the mechanism of this association to determine whether it's causal. But that is a useful conclusion. You have to turn that math back into biology. We have some math here, some hazard ratios, and so on. That's got to be turned back into biology, something that you're actually going to do that will affect either the research we do or the patients we see. A result is not a conclusion. Okay. So here's the fifth slip up. So this is pretty much a cut and paste from a paper. Mean gestational time was 36.345 weeks in the experimental group compared to 36.229 weeks in the controls, and the p-value is 0.6945. Now, I hope you can tell that the problem here is ridiculous levels of precision. Once we know it's non-significant, 0.7 is fine. for the p-value. No one's going to say, the p-value is 0.6945. That means something cool. That makes me understand something that, if it had only been 6923, I would have thought something different. A p-value of 0.7 is all you need to know there. And then you look at the weeks. So we're talking about 1,000th of a week is our level of precision, which is close to about 10, 15 minutes. And I always imagine that, very close questioning of the pregnant couple. So, you came home from the bar and you sat on the couch, then what happened? That's not what we do. It's ridiculous levels of precision. Now, people say to me, well, Andrew, why do you care so much? Why don't you just ignore those additional levels of precision? Just, p-value is 0.6, ignore the 9, the 4, and the 5. But I think there's a deeper point here, which is I want people to think about what they're doing when they do statistics. I want them to be very conscious and careful. I want them, when you write a scientific paper, I want every number that you write down, I want you to think about it. I want you to think through whether it's meaningful and whether it's true. So this is the 6th step up. So key 67, which is a marker of essentially cell division, is found to be a predictor of recurrence. And so the authors recommends that key 67 be measured to determine eligibility for adjuvant chemotherapy. So what we have here is a confusion between statistical significance, which is that p-value of 0.03, and clinical significance, which is that key 67 be used in clinic to determine who gets what treatment. This is an error that I actually would relate to a poor conceptual understanding of what statistics is all about. Because let's think what this p-value 0.03 is really telling us. The null hypothesis in this study is that key 67 is unassociated with recurrence. The p-value is low, so we reject that null hypothesis, and we conclude that key 67 is not unassociated with recurrence. Now, when you say that, no one would say, oh, it's not unassociated, we better go and measure that and determine who should get what type of chemotherapy. They would say, oh, okay, that's interesting. We've got the inference. Let's go and do some estimation to see how large an effect it is. So don't confuse clinical and statistical significance. A statistical association, a low p-value, is not grounds for a change in practice. Okay, so let's go back to what we said was the biggest slip up, which is not involving a statistician. What can you do about it? And so really there's 3 different levels that you can have. So there's a consultation, a collaboration, and a partnership. So a consultation, and we have here at Memorial Sloan Kettering, we do actually have a consulting service. And what happens is an investigator picks up the phone and calls a number and says, I need a statistician to give me a p-value. I need a statistician to give me a sample size calculation for a trial. And the statistician would be called in, does the work, and then you're done, and then you don't speak to each other again. So it's just a one-off thing. A collaboration is you're working with somebody for many years. So the classic example is in urology. I've worked with the urology team for many years. Any urology project will go to me, whether it's a clinical trial and I'm asked to do the sample size calculation, or there's some paper they want to do and we're being asked to analyze the results. That's what my team does. And the next level really is a partnership, and I've been very fortunate that here at Memorial Sloan Kettering there's some very progressive ideas of how statisticians should be involved in research, and they really do treat me as a partner. So it's not that I sit and wait to get the data and then analyze it. I'm really part of the team determining what kind of research we should be doing and what our vision is, and whether we should be doing one sort of trial rather than another. And that is why I have been the first author of urology papers. Now, there's, of course, the other thing that I've already discussed is do-it-yourself statistics and why that's a problem with using software. There's an interesting analogy here with dating. So a consultation is like a one-night stand, and a collaboration is dating, and a partnership is marriage. I won't some people sometimes ask why I don't put do-it-yourself statistics on this particular slide. I'll leave that to your imagination. But it's, the one-night stand, it's quick and easy to organize. You don't actually have to like the statistician. There's no commitment involved. It's a very close analogy. Statisticians don't like it, right? They're like, well, hang on, I wrote your stat section for your grant. I never heard from you again, right? I wasn't involved in the paper. And so what tends to happen is that we don't care, so we don't really do a good job. And what am I going to do? I've been working with Dr. Jones for years, and we've got a great relationship, and we're doing some really interesting studies on prostate-specific antigen. And then Dr. Smith calls me up. He wants me to do a sample size calculation for some trial. I'm not going to do this. Hey, wait a minute. I'm busy. You can go to the bottom of my pile. So I generally don't recommend them. They do fulfill a need, just like a one-night stand, but they don't do a particularly good job. So I really think you've got to think about a more long-term relationship. I think one of the most important advantages is this second one. The average statistician is not going to make a statistical error. They're not going to make some error with the math or give you the wrong number in a regression analysis. How they're going to make an error is because they don't understand the medicine, or they don't understand the science. And I can tell you just a very brief story. I was involved in evaluating a prostate cancer marker with a commercial company, and we found out that the marker didn't work. The commercial company got very angry, and they hired their own statistician, and I was essentially accused of fraud and incompetence. And they said that I got everything wrong. What it came down to in the end, the denouement was I was on the telephone with the statistician they hired, and we said, okay, we've got the data set, you've got 974 patients, I've got 974. Great. You've got 27 events, I've got 27 events. Great. Okay, and then we said, right, let's run the regression. What do you get for PSA? I've got a coefficient of 2.7. I got one of 2.7. Great. And then the next one was, he said, what's your coefficient for Gleason grade? And I said, do you mean 7 versus 6 or 8 versus 7? And he said, no, just Gleason grade. And it turns out this statistician didn't know that Gleason grade was grouped. He just thought it was some continuous variable from 2 to 10. And so he'd got a wrong result, not because his math was wrong, but he didn't actually understand the medicine. He didn't understand that these were categories, the groups that were put together by pathologists. And people on my team, they can tell you exactly when what happened in the 2005 IUSP report, and then what happened in 2016 with cribriform becoming higher grade cancer. They know all that, and they're going to give you better science. The downside is you've got to find someone. I really don't know what the situation is in Brazil, but that can be quite challenging in the US. You're at a hospital, there isn't a statistics department. If you're in a university, there is a statistics department, but they do theoretical work, and they publish math papers, and they don't actually work with clinicians at all. And then once you find a statistician, it's like a relationship. You have to find someone that you get on with and that you understand and that is interested in your work. One of the problems is many statisticians are really interested in math, and they're not that interested in, say, bladder cancer, and so they're not going to do a job for you. Some other cons, you've got to pay for the statistician. I have to support my staff. I've got to support my own salary. If you're on a grant, you're going to have to get a grant. You're going to have to put me on the grant. You're going to have to give me some funding. And the other thing is that it's not like a waitress. You're not going into a restaurant saying, I want a medium rare steak with a side of fries. It's a relationship, and so you might want something, and I say, here's a better way of doing it, or what you're saying is actually erroneous, and you can't do that, and you are going to have to change your mind and grow. So just a few, just in finishing, a few little sort of hints and tips for you. This is a paper I wrote with Dan Soberg, who's a colleague of mine at Memorial Sloan Kettering. You can find it online very easily. It's a guideline if you're going to report statistics in European Urology, which is, as the by far the highest impact urology journal. Here are some hints and tips on how to do that, but of course you can take those on board for any journal you want to submit your papers to. Here's another paper you could look at called Writing Up Clinical Research, a Statistician's View. And you can see there, how do you write up an introduction section? So what do you need to say in that? What do you need to say in the discussion? So those might actually help you a little bit. So going back to our original question, what is a p-value? So this is a book that I wrote called What is a p-value Anyway? 34 stories to help you understand statistics. The reason I called the book What is a p-value is because I've given this talk to dozens of times to hundreds or perhaps thousands of doctors all over the world, and I've always asked them this question, what's a p-value? And only in one case have I ever had someone who's given me the correct answer. And just to explain what is actually a p-value, the p-value is the probability that you will see data that you observed or something more extreme if the null hypothesis were true. So the common mistake, and the mistake that you actually made, was say that the probability, the P, which stands for probability, that the probability is about the hypothesis, not the data. And just to explain why that's wrong, let's just imagine that I had 3 coins in my pocket. I take them out of my pocket and I toss those 3 coins, and they all come up heads. Now, let's just assume, if these are fair coins, we can say, well, what's the chance that I would get 3 heads? And it's half times a half times a half, which is an eighth. Very easy. If I'm going to throw 3 coins and they're fair coins, so that's my hypothesis. What's the chance of the data, the 3 heads? It's 1 in 8. Now, put it the other way, though. I got 3 coins. I toss the coins. I get 3 heads. What's the probability that the coins are fair? There's actually no way of doing that. So you can't actually go from the data, in this case, 3 heads, to the hypothesis, the coins are fair or not. But you can go the other way around. You can go from a hypothesis, the coins are fair, to work out the probability of the data. So the point about a p-value is we're saying here's the probability of the data if our hypothesis is true. Now, if the probability of the data is low, the p-value is small. If our hypothesis is true, then we could probably say our hypothesis is not true, and we'll reject our hypothesis. So that's what I write about in the book. It's all told in little stories. Here's what I write about multiple testing. Boy, would you like to have lunch one day, just you and me? Girl, no. Boy, but I thought you said I was cute. Girl, I never said that. Boy, you laugh at my jokes. Girl, because they're so stupid. Boy, is there nothing you like about me? Girl, well, your fashion sense isn't entirely misplaced. Boy, hopefully, so you will go out with me? Girl, no. And that's exactly actually much of what happens in my daily life is that an investigator says, well, did the drug work? And I say, no. And they say, well, what about in older people? I say, no. And what about in younger people? No. What about in women? No. What about in men? No. What about in older men? Oh, well, the p-value there is 0.04. Oh, so the drug does work. No, in fact, it doesn't. So that's how I try and try and explain various statistical concepts. Here's another one. So it's all illustrated with cartoons. What does it mean? It means that our answer is 0.008. To understand what stats means, you really have to understand the concepts. And I hope you'll appreciate that biostatistics is a little bit more than mathematical calculation. It's using some ideas. And if you understand those ideas, you're going to understand a lot more about biostatistics, and you're going to avoid some elementary slip-ups. So that's the end of my talk. I'm very happy to take some questions.
Any question? Any question in Salvador, in Rio? So yeah, well.
No worries, it's okay.
Do you have any question? So just to share some thoughts here, we have a very big problem here in finding someone to do statistical analysis for us here.
Yeah.
So if it is hard in the United States, imagine here in Brazil. So
right.
What we are doing so far is to have like one night stand and hire someone to do statistical analysis for us. And most of times, what we see is like basic mistakes, just like you showed, like our the one that is hired for doing statistical analysis for us is comparing randomized groups, like demographic data, and you know, sometimes we probably feel like we should have done it, but we
done it yourselves, you mean?
Yeah, well, but we know we cannot do it well, so so that's a huge problem we have here. I don't know how it is in Salvador and Rio, but probably the same. And well,
so I mean, so the question is, how do you build an academic infrastructure? How do you build a program? And this is the question that you might have had in urology 60 years ago. How do we develop an academic program in urology? Because we need some people who can do procedures, who can do TERPs and take out stones, and we also know people that need to use drugs to treat urologic conditions. And so that's a question that urologists had to solve over time, is how do we develop our infrastructure? How do we train people up to become good urologists? Should we have subspecialization, uro-oncologists versus non-oncologic urologists? And I can't solve that problem for you in Brazil. I can only tell you what the problems are and how you need to think about it. And the one thing that I would really suggest is that you need to find people, and most of the people I hire, by the way, most of my colleagues hire people who have master's degree in statistics, and they come along and do their statistics. I actually hire smart people who know some math, and they know some computer science, and they have a bachelor's degree, and they just actually learn the statistical techniques, and they learn the methods, and they learn the programming in my group. And the advantage of those individuals is you're not finding people who. It's like the whole thing about, you know, if you have a hammer, everything looks like a nail. You're having people who really want to do medical research. They're really interested in finding out things about urology and about cancer, and the math is a tool for them doing it. And those individuals end up becoming very good statisticians because they really care and they want to get it right. The downside is obviously you need people to train them, and we're fortunate, you know, I can train them, and Dan Soberg can train them, and now Melissa Arsel is training them, and that's the challenge you'll have there. How do you actually train people to have a good basic statistical knowledge, understand about the programming, but also really care about your work? So they'll read up the latest PSA papers, and when you're talking about what PSA, or you're talking about a Gleason grade, or they're talking about a nephrometry score, they know what you're talking about, and they can be scientific collaborators and can give you good advice and feedback.
Yeah, probably gotta send someone for you to train over there and then bring him back.
We do actually do that. I mean, right now we've had quite a few fellows come from Italy.
Yeah,
and they come here and they work with our group for a year, and then they go back to Italy, and then they work with people in Italy to try and build capacity. But I think it's going to be a long-term view. Like, that's why I used the example in urology. It wasn't as if in the 30s or the 20s they said, here's how we're going to do it, and suddenly you had all the urologists that were appropriately trained. This was a multi-decade process of building capacity.
Yeah.
Do you still have some?
Sure, please, go ahead.
Yeah. Dr. Vickers, thank you for your lecture. This is Daher. I was there 10 years ago already.
Okay. Now I look closely. The Daher Shade. Yes.
Yes, thank you.
There you go. Hey, how are you?
Good, thanks. Well, I remember some of your lectures and so on, the things that are very important, because it's a real different way of thinking and the concepts. One issue that we also involved here is the quality of the service. And I remember when I was there, you were starting some work showing the physicians their results individually.
Yes.
And comparing to the rest of the group. Could you share that with us?
Sorry, I didn't hear. Could you repeat the question?
So, how important do you think is to evaluate the results of each surgeon in a group and compare it with other groups? and to make things better and show. I remember, for instance, you were analyzing at the time surgical margins and impotence and incontinence.
So it's a little off topic, but I'm happy to talk very briefly about surgical quality assurance. I think the point is that surgeons are one of the few groups of professionals that don't know what their results are. An example I give is that my brother-in-law is a bonds trader, and he works in a group, and I say, how do you know how you're doing? And he will talk for 20 minutes. Well, at the end of every day and the end of every week, we have this certain breakdown. We have what's called a hit rate, and we get the hit rate for each team and then each individual, and we do that by week. And they'll go on. They know exactly how many bonds they're selling, how much profit they're making on the bonds, whether they're, on what proportion of bonds they're making a profit. In surgery, what happens is that someone comes and sees you and you do the operation, and commonly they come back after 6 weeks and they don't seem to have any complications, and you say, right, that's good. Now, it's not just a problem in urology. I mean, my wife had a minor knee procedure and went back after 6 weeks, and the doctor said, oh, there's no inflammation, no complications, you're good to go. This doctor has no idea whether my wife is still in pain. He has no idea what her functional status is, right? The actual slide I show is of the World Cup, of Goetze scoring the winning goal in the World Cup against Argentina. That was a good moment for you guys, right? You enjoyed that, right? Yeah. So I actually show that slide and I say, what happens next? And everyone says, goal. And I'm like, no, the ball was discharged to primary care and no one found out. Can you imagine if a soccer player, every time he kicked the ball, never knew whether he completed the pass? That's the problem that you guys are in as surgeons. And you can't, it's very difficult to get better unless you know what your results are. And so I think monitoring those results and trying to get some idea of whether they're good or bad is absolutely critical for surgeons to try and improve and give a better service to their patients.
Dr.
There's
Vickers,
a question, please go ahead.
My name is Rubens, and thank you for the lecture. And I have a question more of a practical view. Since we don't have the funds or the people to help us, we have a couple of projects, ongoing projects, and they didn't have that ideal design with a biostatistician and all the things you said. And the thing is, I don't see in the short or the medium term here, because the people who can change it that didn't even attend to this class. But the thing is, how do we get up from the a project that it's running, a study that we're already ongoing, and how do we make it better? I mean, I know that it's not ideal as you when you make the question with a statistician, but how do you make better data? I mean, after the study's already started, it's ongoing study. To change it a little bit, because we're starting to make a database and trying to improve in that area, but everything is based on individual efforts and not always and with knowledge, more effort than So how do you suggest to take on these problems?
Yeah, it's very difficult to do without some level of institutional or departmental support. And I don't mean that in a purely financial sense, right? Yeah, I mean this in a more general sense. If the people who are in charge at your hospital are not into research and don't think it's important, or your department chair doesn't think it's important, then you're going to have a problem. If they say it's important, but they don't actually put their money where their mouth is. Oh yes, with this hospital, we've got to prove that we're up there with Memorial Sloan Kettering. We've got to actually publish some papers in the good journals, but they're not providing any resources for you to do that, any structures for you to do that. Then you're going to have the same problem, right? You cannot. It's very difficult to do science at your kitchen sink. Right, you need an appropriate structures to do that. You need appropriately trained people, and they need to be given the time to do their research. And you as clinicians need time off from your clinical work to invest in doing your research. You need data managers. Okay, how are you going to? What data are the statisticians going to analyze if you don't collect those data and curate them and look after them carefully and make sure that those data are high quality. So I think a lot of these conversations have got to be with people who are higher up in the institution or in the department and say, look, do you want us to do this? Do you want us to be writing papers? Do you want us to be trying to find stuff out in order to treat our patients better? Because a hell of a lot of what we do with our patients every day is based on research. We want to practice evidence-based medicine. We want to do better for our patients. And if we want to do better for our patients, we better find out what works and what doesn't work. But if you want us to be doing that, then we need to do that properly, right? If we want to go and eat a steak right now, we need a steak and we need a stove to cook it, and we need some plates and some knives and forks, right? We can't sort of magically somehow get a meal out of nothing. So that's the conversation that needs to take place. There has to be appropriate academic structures and appropriate academic support in order to do high quality research. And that's going to involve a serious approach to data management and a serious approach to having statisticians as part of the team who understand what you're trying to do and want to support your work and want urology research to be better.
Yeah, thank you.
Juliana, Dr. Vickers, I'd like to thank here from Salvador, because we are doing our first steps to find out, to follow our data and to see what's going on with our surgeries. We don't have really a project going on so far. We are still drawing it. But as I see, it takes dozens of years to get to a real place. And it's real nice to have this enlightenment. Thank you for the talk.
You're very welcome. Very welcome.
Yeah, so I think we can finish. Thank you so much for your wonderful lecture. It's always nice to hear your presentations, and it was very good conversation here. Thank you so much.
Okay. Thank you for inviting me. Bye-bye.
Thank you. Bye.